I'm joined today by Dr. Chirag Parikh and Dr. Sherry Mansour of the Program of Applied Translational Research here at Yale. Full disclosure, I'm part of that program, but had nothing to do with the paper we're discussing today, which examined kidney function markers in long-distance marathon runners. Dr. Parikh, Dr. Mansour, thanks for coming to talk with me today.
Thank you for having us.
Thank you, Dr. Wilson.
So your study just came out, and it's a small study, right, of around 22 marathon runners. And Dr. Mansour, why don't you tell us what you did with these individuals and what your main findings were?
So we measured urine and blood samples from these runners, and we measured it at 3 time points. We measured it a day before they ran, and within 30 minutes after running, and a day after they ran. So we looked at some blood levels of kidney function like BUN creatinine, and we also looked at biomarkers, and we also assessed their urine under a microscope. And we found that actually 82% of all runners developed acute kidney injury.
So that sounds like a very high number, but let's go back to acute kidney injury. So Dr. Parikh, what do you mean by acute kidney injury? What's the definition there? And we normally associate this with patients in the hospital, am I right?
Correct. Acute kidney injury is a common condition in hospitalized patients. We see it frequently after cardiac surgery or in the patients with medical ICU. We typically diagnose it by serum creatinine, which is a marker of filtration and tells you about the kidney function. So an abrupt increase in serum creatinine suggests that there is a loss of kidney filtration, and we diagnose it as acute kidney injury in the hospital. Typically a 50% rise in serum creatinine or a 0.3 absolute increase would be considered as acute kidney injury in the hospital.
So 82% of these marathon runners met that criteria. Just for comparison, what percent of cardiac surgery patients develop acute kidney injury after cardiac surgery, Dr. Parikh?
We have done several studies in the cardiac surgery patients, and roughly 1/3 of the patients develop acute kidney injury after a bypass surgery in the hospital from our studies.
So Dr. Mansour, so 82% of marathon runners, maybe 1/3 of cardiac surgery patients. Should we be concluding here that marathons are more than twice as bad for you as undergoing cardiac surgery, or am I jumping the gun there?
It's hard to say that. All we know from our study is that there is short-term damage to the kidney with marathon running. All of our runners went back to baseline within 48 hours after marathon running. But that being said, they had urine that is similar to very sick patients in the ICU, and they had biomarker levels that, again, is very similar to very sick patients in the hospital and patients who've had surgery.
So I want to bring up this picture. You guys did urine microscopy on all these patients before and after the marathon. And Dr. Mansour, can you just walk us through what we're seeing here in these urine microscopy pictures?
Yeah, sure. So you see that initially the runners before they ran, there was nothing really in their urine, no cells. But then after they ran, you start seeing these sort of brown cast-looking things, and that's what we call muddy brown cast or granular cast. And it really is significant for intrinsic kidney damage in the tubules. And that's something that we find a lot of the times with acute tubular injury, ATN. So we do know from the microscopy that they do have intrinsic kidney damage.
So we're seeing these casts are made up of dead cells, cellular debris,
yep.
Cells that have died. So Dr. Parikh, what does that tell you about the mechanism here? Is this simple dehydration or volume depletion, or could something else be happening?
No, this is a great question, Dr. Wilson. And this study is unique because most of the prior studies before our study only measured serum creatinine, which is a filtration marker. We went a step ahead and wanted to see the structural changes in the kidney. And urine microscopy is a very simple way to see if there are cells or dead cells present in the urine or debris present in the urine. So this presence of these cells and the findings in urine microscopy tell us that it is not just simple dehydration. Because if it was dehydration, usually the urine is bland, and we call it prerenal azotemia in medicine. Here, the cells are dying either because of prolonged ischemia or because of ischemia happening in a short time that actually caused cells to apoptose or necrose. It could also be related to toxins that are released from the breakdown of muscles, or even heat stress, which is very well described in other settings like army workers or sugarcane farm workers, where intense temperatures or increase in core body temperature can cause death of kidney cells. So this is just not simple dehydration.
And we have a number of lines of evidence here. You guys measured several different biomarkers in the urine and blood, biomarkers of injury and repair. Dr. Parikh, any patterns there that are worth noting in these advanced biomarkers?
Yeah, so this is a very exciting line of research, and the place where nephrology is moving ahead, where we can find better tools to assess the kidney injury along with serum creatinine. And we have measured all of these biomarkers in the ICU and cardiac surgery. It was very surprising to see that the increase in biomarkers from health or from baseline was about 5 to 10-fold elevated in soon after marathon running, very similar to what we see in the cardiac surgery and ICU patients. Fortunately, we also saw that the repair biomarkers go up along with the injury biomarkers. The inflammatory biomarkers also go up. But by day 2, most of these biomarkers are coming down as the recovery is taking place while the athletes are resting.
So you think there's probably some ongoing repair happening even days after the marathon. Should that tell you that our patients should be careful about long-distance running with doing repeated marathons close together, as some really high-powered athletes do?
Definitely. I think at least in the sick people or in hospitalized patients, we have a lot of evidence that is suggesting that recurrent acute kidney injury events can cause progressive chronic kidney disease. So it's likely that if some athletes have underlying diabetes or hypertension or even older age where repair takes a longer time, then not allowing adequate time for recovery after a marathon can cause accumulation of multiple injuries over time and can lead to fibrosis, or what we call as chronic kidney disease.
So Dr. Mansoor, I'll close out with you here. If you're a primary care physician watching this and you have a healthy marathon running patient who comes in and sees the study and says, what should I do? Should I keep doing marathons? Or if I want to keep doing marathons, how should I protect myself and my kidneys? What's your advice to them?
Right. I think based at least on our findings, we can tell them that there is short-term damage to the kidney. However, it does resolve within 48 hours. But just typical things that we should always advise anyone who is going to undergo a marathon is to keep themselves well hydrated, to avoid taking NSAIDs before running, to make sure that if they have comorbidities like Dr. Parikh mentioned, diabetes, hypertension, heart disease, to really communicate with their doctors about these comorbidities, and if running 26.2 miles is really the best thing for them. More importantly, while running, to keep yourself during the race well hydrated. And also the frequency of marathons, it's hard to tell now, and that question remains unanswered, but the training and how intense the training is might also play a role in damaging the kidney. So to just talk to your physician about all these things would be very important for patients who are interested in running.
Great. Well, thank you very much. Congratulations on the study. Really interesting stuff.
Thank you, Dr. Wilson.